I'm co-sharing this with Angela, and this afternoon we'll take not a wide walk on the wide side, but a walk on the left hard side. So it's my pleasure to present the first speaker, Ricardo Costa, degenerated small aortic prosthesis with high risk of coronary occlusion. Be my guest.
Muito obrigado. É um grande prazer estar aqui, falando em português, representando a Sociedade Brasileira de Hemodinâmica e Cardiologia Intervencionista, SBHCI. Nós temos tido o privilégio de termos uma parceria com a APIC nos últimos anos e sempre tendo representantes participando dos nossos congressos. Esse ano tivemos o Dr. João Bruno, ano passado o Dr. Rui Teres, que aqui está conosco. Temos feito sessões conjuntas também, importantes eventos, como o EuroPCR, junto com a doutora Rita. E é um prazer estar aqui. Eu trago o abraço de toda a comunidade brasileira, todos os senhores, para participar desse congresso e dessa sessão. Eu devo falar inglês, certo? Okay. So I'm going to now switch to English. So I have to first say hello in my mother language. So this is a quite challenging topic as we have been expanding our indications and doing procedures in TAVR, more complex subsets and anatomies, but we still don't have much of the evidence that we might need. So first of all, very important to understand what is the bioprosthesis key failure mechanism. This recent study showed that indeed it is calcification. The main mechanism observed in these explants study in vitro after they have been removed. And interestingly, the location of this process, inflammatory process leading to calcification, it follows the hemodynamic and biomechanical indicators, as we have been demonstrated elegantly in this multimodal study. The modes of bioprosthetic valve dysfunction, when we consider only TAVR, we do have the structural mechanism with permanent intrinsic change of the valve, fibrosis, calcification, tear, leading to different degrees of dysfunction, as well as abnormalities not intrinsic to the valve, like bioprosthetic regurgitation, PPM, malposition, late embolization. And we have also been learning the long-term durability, which is a hot topic of this theme, and it looks like in the 7 to 8 years, that's when we see some more important inflection of the curve. And when we deal with small annuli, it's very common in surgical procedures, ranging from 22 to 44%. And even in studies with intermediate risk trials and low risk trials, this has been a relatively high representation. TAVR and SAVR speaks for 70 to 80% of the cases, and also a very important representation of women in this particular subset. Important to say that when we analyze the predictors for severe PPM, we find female gender, valve-in-valve procedure, as well as valve size less than 23, which is, again, an indicator for small annulus. And severe PPM has been associated with increased cardiac mortality, greater structural valve deterioration, as well as other mechanistic impairments of the LV function. This well-known study was one of the first ones to collect the information for a better understanding. What are the implications and predicts for coronary obstruction following TAVR procedures? And this study included a large number of patients in this registry, conducted by Henrique Ribeiro from Brazil. And we can see that according to the valve type and procedure, there has been a difference in terms of self-expander, worse outcomes with the balloon expander. I know there's more recent evidence challenging that to some extent, but also it calls attention for valve-in-valve, already highlighted as an important predictor as compared to a native aortic valve procedure, with no significant impact in terms of transfemoral, transapical, transaortic access. The range of coronary occlusion post-TAVR, nowadays it's considered to be less than 1%, but we can see historically It's decreasing over time, but anything between 0.5 to 3% has been shown in different scenarios in different registries. And as for the type of surgical bioprosthesis, in this another sub-analysis from Henrique Vivid Registry, demonstrated that depending on the type of the surgical prosthesis, we have also a increased risk for that outcome. Important to define the mechanism of the failed bioprosthesis, so whether it's stented, and also the height of the coronary, the VTC, as well as the stentless prosthesis, as well as we can see according to these parameters. There are some more recent studies that have specifically tried to assess the role of, in this study just presented as a late-breaking trial TCT, the transcatheter surgical aortic valve replaced for severe stenosis in small aortic annulus by Dr. Cabal. And in this study, the main anatomic criteria was small aortic annulus, as defined as mean diameter less than 23, minimal diameter less than or equal to 21.5, as evaluated by CT. And the primary outcome was severe PPM and or moderate severe aortic regurgitation. The valves used in this study was the SAPIEN 3 Ultra of Evolute and Accurate, and valve size was according to the manufacturer recommendations. This population was not a large study, a little bit more than 150 patients, and complete follow-up was performed in the majority of the patients. And here we highlight the mean age was 75 years old. Women represented more than 90% of these patients. Here's the primary outcome, the PPM at 60 days. There was increase in SAVR, 10.3%, 5.6% with TAVR, but were no statistically significancy. There was also comparable hemodynamics over time in terms of the mean gradient, as well as the mean orifice area. And as for the follow-up, there are no significant differences in the key safety outcomes. There was only change in the new onset atrial fibrillation, which was three times higher in the surgical group at the mean time of follow-up of 2 years. No significant difference in terms of the functional status, as well quality of life. And as the limitations, there's the early termination of this trial along with the lower than expected rates of PPM. And as the conclusions, the authors consider that based on this, still we have no evidence of contemporary TAVR superiority over SAVR regarding valve hemodynamics in this particular subset of small annulus, and we're dealing here, of course, with native valves. Another study that specifically addressed the technique on this subset was presented this year at the EuroPCR, compared chimney stenting versus basilica for the prevention of acute coronary obstruction during TAVR, and this is well-described techniques as well known. And in terms of the main outcomes, female gender was already more than around 2/3 of this population. We have, in terms of the CT analysis, the annulus minimum diameter was 20.2 in the chimney group and 19.4 millimeters in the basilica. And here the technical success was comparable between both groups. There was no significant difference, very comparable in terms of the MACE outcomes after 1 year. Cardiovascular death, though, was numerically higher in the chimney, 6.7% versus basilica, 1.3%. 90% of this population, more than 90%, was valve-in-valve. And based on the design of this comparison, which was not randomized, was the first one comparison performed and presented, appears that both techniques were comparable, but with better outcomes in terms of survival, numerically speaking, for the basilica in this particular scenario as a prevention for coronary obstruction. What we have to expect in the future, near future, there's some trials being designed. The SMART trial design is specifically addressing, again, TAVR in small annulus with the randomization stratified by gender, and there's a comparison here for the self-expanding versus balloon expandable valve. There's also the REA trial, which is ongoing, TAVR versus SAVR in women. And there's this trial, the baseline trial, SAPIEN, balloon expandable versus self-expanding valve, again, in failing surgical aorta by prosthesis. All these trials will give much more information, adding knowledge for what's the best approach, the best technique, and the outcomes for a patient with small annulus as well as failure by prosthesis with a good representation of small annulus as well. Thank you very much for your attention.
And now we'll listen to Francesco Saia with the team evaluating CAD severity in aortic stenosis.
Thank you very much. I admit I was enjoying the Portuguese sound, but unfortunately, I mean, you had to switch to English, and I cannot speak Portuguese, but something I understand. Thanks for the invitation. This is the topic. Coronary artery disease is highly prevalent in patients with aortic stenosis, and this is because they share common risk factors. This is well known. Important issue is that when significant multivessel coronary disease is present, this can shift a little bit the choice of the procedure favoring surgery. So this is something that we have to keep in mind for patients at intermediate to low risk, surgical risk, because we know the advantages of surgery when coronary anatomy is very complex, and this is derived from all the studies comparing surgery with PCI. So we have to keep this in mind. So this is an important factor. When we are in the presence of coronary disease and we need surgical replacement of the valve, the indications of the guidelines are clear. We should revascularize all the lesions higher than 70%. So it's anatomical indications. You can see that here the evidence is C, but actually in the guidelines is not reported like just opinion. It's based on all the data, but still some data not randomized. And CABG should be also considered in patients with lesions between 50% and 70%. So again, an anatomic indication. So what is the background? The background indicated in the guidelines also is because there are data showing that concomitant CABG for all lesions has been shown to reduce late risk of mortality, whereas incomplete revascularization is associated with greater dysfunction of the left ventricle postoperative and a reduced survival. So it is important to revascularize all the severe stenosis. And then we know that hypothetical redo intervention is a high cost for the patient in terms of course, health, subjective perception of the intervention. So something that could be interesting is to think about FFR, so physiology-guided revascularization in these patients. We don't have data. So what we know from non-aortic stenosis patients is that indeed using physiology evaluation, many patients, 1/4 of the patient in FAME3 could be reclassified from a high syntax score to low, you can see below 22 syntax score. So this is something that we know. And we also know that when we apply a graft on lesions that are not physiologically significant, the likelihood to have occlusion of the graft is almost 6 times higher. But this is, again, comes from not aortic stenosis setting. So it's something appealing. But when we are dealing with aortic stenosis, we have to accept the fact that the evidence in this moment is not sufficient to support the use of physiology evaluations for coronary lesions. And this is consistent in European revascularization guidelines, European revascularization guidelines on valvular disease, and American guidelines. So this is the situation nowadays. So what about TAVI patients? The situation in TAVI patients, of course, is different. We can stage the procedure. We can think about a different approach. We are dealing with different patients. So there are several open issues. I will not go through all these issues, especially PCI before or after TAVI, and the issue of coronary access are a little bit beyond the concept of evaluation of coronary lesion. But I think those 3 issues are all important to the overall evaluation of the patient. So should we treat by standard coronary artery disease? How to treat these lesions? And of course, anatomy versus physiology, again, back, which kind of data do we have today? So should we treat by standard coronary artery disease? According to the guidelines, it's a yes. It's again a class C evidence. It's a 2A class of recommendations. And this is again anatomically based. All coronary lesion in proximal segments or left main greater than 70%. But again, as I mentioned, this is both in the European and American guidelines. But this is a C level of evidence. When we look a little bit at the scenario reported in the literature, most of the study do not report an important impact of coronary artery disease, the presence of coronary artery disease on the outcome of the patient. So why should we treat a disease that apparently has no impact on the future of our patient? Number one, this is from our center. You can see that having coronary artery disease up to 5 years follow-up, no impact in terms of cardiac death, having or not having coronary artery disease. And actually, if we look at the evidence, the only evidence that we have nowadays that about revascularization of lesions, you can see that the activation trial enrolling patients with more than 1 or more stenosis with a diameter above 70% in a major epicardial vessel, you can see that there is no significant difference in terms of the endpoint death of rehospitalization at 12 months, and there is a strong, significant signal in terms of increasing bleeding in these patients. So actually, the evidence is against doing revascularization in our patient. But we have to consider exclusion criteria. We have a patient with recent ACS, left main disease, or patient with significant angina were excluded from this trial. And this trial has major issues in terms of enrollment. It was stopped prematurely. It was very low enrollment. You can see here the rate per center per year. And But let's focus on which patients were enrolled. So this trial enrolled patients 84 years old on average, patients basically without angina or minor angina, patients with basically one vessel disease, and we have no data about the site of stenosis, proximal, mid, distal, so we cannot call this evidence as conclusive. Okay, so which patient or lesions should we treat with PCI today? So we evaluate the lesions in order to treat. And I think, we have enough data to go for complete revascularization in patients with ACS. We have this data outside of the aortic stenosis setting, but we have also some suggestions in aortic stenosis patients that ACS is associated with worst outcome. And so I think we have enough to go for complete revascularization of major vessels at least. And I think that we can concur with guidelines that when we have a lesion of very proximal LAD or left main, this is something that none of us, I think, would like to live like that in a patient with aortic stenosis without any further evaluation. Of course, borderline left main, we can evaluate with what we have in our hands today, for example, IVUS, and I will touch the physiology later on. So, and again, this is, a proof of the fact that, again, 1, 2, or 3 vessel disease maybe does not have an impact, but having a LAD disease may have an impact on the outcome. This is the French 2 registry, large registry. So I think it is reasonable to to think that left main and proximal LAD could be revascularized with our evidence and based on our evaluation, basically anatomic or maybe with imaging. So how should we treat coronary artery disease in this patient? Because if it's true that maybe overall coronary artery disease does not impact the mortality over long term, it is also true that there are several suggestions that having a high burden of the disease, high syntax score above 22, is actually associated with the worst outcome. So it's something that is kind of red flag for our patients. And indeed, going again to the France registry, we see that having in these patients incomplete revascularization is actually associated with a worst outcome, significantly worse. So maybe this patient deserves something else. And actually, as usual, we have some torture of the statistics in order to derive some actionable data. And what we know that is that this goes toward the concept of complete revascularization when we have a residual syntax score below 8. So meaning that we did quite complete revascularization, PCI becomes actually of advantage for the patient, for TAVI patients. So it's something that when there is a high burden of disease, we should consider a revascularization of the patient. And maybe when we have some categories of patients that are a little bit different from the others, again, the impact of syntax score, this number 22 comes in several studies. So I think it's something that we can keep in mind as prognostically relevant. When we deal with patients with reduced ejection fraction, like these patients, in this case, maybe having a complete revascularization may be of help to improve the prognosis of the patient. So this is something that, anyway, hopefully we will have more answers from this trial that is ongoing. We will have the results in 2 or 3 years. Is complete revascularization versus no revascularization of bystander lesion. But again, this will be based on anatomy. Hopefully we will have subgroups analysis to try to better target our procedures if needed. So today I think something that we can do reasonably is to put into, I don't want to go through this is an algorithm, but I think deciding to do something as a mix of clinical evaluation of the patient, so the status, anatomic evaluation of the lesion, the site of the lesion, and also the complexity of the lesion and the risk of the lesion, and some technical evaluation also in terms is the patient taking oral anticoagulants and so on. So it's a balance that we have to take. It's not the evaluation of the lesion, it's the evaluation of the patient overall. And again, when you do something like that, this is again from our series in Bologna, it's quite a large series. You can see that doing reasonably incomplete revascularization actually works in terms of 5 years outcome. This is, sorry for the self-quotation, but this is not self-quotation. This is a Revasc TAVI trial, multi-center international trial. Again, there is the concept that when you apply reasonably incomplete revascularization, so when you revascularize lesions that are clinically relevant, then at the end you end up with no difference between complete and incomplete revascularization. So last point, anatomy versus physiology. Maybe this is a little bit the last frontier in terms of evaluation of the lesions to treat or not to treat. And what we know is that when we have aortic stenosis, there are important changes in the physiology. So we have to consider that there is a reduction of the flow, forward flow. There is there is a backward pressure coming from the compression of the microcirculation, and something that is completely reversed after TAVI. So in general, we should consider that the evaluation in theory should be better to do after TAVI. But how can we summarize all these changes that we have? Because there are several studies, I cannot go too much into details, but the summary is this, that FFR may be false negative because the coronary flow reserve is impaired, for what I said. But on the other side, what is reassuring is that the negative FFR value before TAVI rarely cross the point of cutoff value after TAVI. I will show you the study from the group of Verona showing this. IFR has a theoretical advantage because it's based on the stability of the resting coronary flow before and after TAVI. But on the other side, we have that there is a baseline increased resting flow. So maybe there are some suggestions that the cutoff that we need in this setting with IFR should be a little bit higher in order to avoid misinterpretations. So this is FFR, again, the summary of what I said. We have some atrioventricular uncoupling, so we have a decrease in PA, we have an increase in PD because of the microcirculation dysfunction and the external compression. So we have the possibility to have false negative FFR in many cases. But again, this is the study from the Verona group showing that only few patients actually measured before and after TAVI crossed the line. So in theory, FFR will be better measured after TAVI, but overall, we can have a good idea even if we measure before TAVI. IFR, again, this is the proof that is stable and reliable, again from the group of Verona. There is no major difference between aortic stenosis, coronary artery disease, but as I mentioned, there is the hypothesis that the cutoff value should not be accurate, so more data are needed in this regard. The FITAVI is ongoing now. This is a trial randomized between angiographically guided group and physiologically guided PCI in patients undergoing TAVI. The primary outcome is 12 months. I think we should have the results maybe at PCR this year. But this trial will certainly tell us which is the best strategy between angio-guided and FFR-guided, but once we decide to revascularize. This trial will not, unfortunately, tell us if PCI is better than conservative management in some categories of patients, for example, the patients pertaining to the activation trial. So you can understand easily that FFR physiology evaluation is appealing, and is appealing because now we know that we also can have this derived non-invasively. There are some data showing that there is even the pre-TAVI value are quite accurate in terms of sensitivity, specificity, and especially negative predictive value. And when we use in CCFFR a cutoff of 0.78, we have a very optimal cutoff to predict also the post-TAVI FFR. So it's something that is appealing, but we need more data. So my conclusion that is for patients with ongoing surgical replacement, nowadays complete anatomic revascularization is still recommended based on historical data. For elderly patients undergoing PCI, especially in the absence of angina, routine PCI should be avoided with the exception of left main and proximal LAD disease. And here comes the concept of reasonably incomplete revascularization in some patient subgroups. In younger and lower risk TAVI patients, we can think about a more complete revascularization with PCI, but there are no data, with the exception perhaps of patients with ACS. And the role of coronary physiology in this setting should be further evaluated. Thanks.
Thank you very much, Dr. Saya. And now we are moving from the AORTIC to the MITRAL, and we are kind of in a transition. And I'm very curious about the next presentation by Dr. Emanuele Barbato, who is going to tell us what's the degree of cross-selling between TAVI and edge-to-edge repair.
Thank you very much. Thank you very much. And it's again a pleasure to be here together with the Portuguese friends. Long-standing collaboration within EAPCI, together with EAPCI, and cannot be any more thankful for inviting me also this year at this edition. The task I was given by the program committee members was to try to learn something from the lessons we gathered from the Valve for Life program as it pertains to TAVI adoption, and whether this can be transferred to transcatheter edge-to-edge repair. Let's remind for a second which were the objectives, why the Valve for Life program was born, and it was born to address regional unmet needs. For Poland, one of the first countries joining, The unmet need was limited funding available for transcatheter heart valve therapies and low penetration of the therapy at the time. For France, again, limited number. This is a leitmotif of reimbursed procedures, as well as a limited number of implanting centers before joining the initiative. For Portugal, you tell it, what was your need at the time? Significant underuse of TAVI procedures when compared to other countries, and this will already portend to an important role that EAPCI, together with APIC, exerted over the year in finding references to which each and individual country can compare their own practice in order to use these figures as a leverage towards the payers, towards the healthcare authorities. There are 2 new countries joining more recently the program, United Kingdom, and the objective there is to facilitate access to life-saving technology, to this life-saving technology, helping implementing guidelines and extended TAVI indications, as well as implementing nationwide MITRAL programs. So you see, more recently, countries are busy to use this program also to boost tier adoption. And Italy, the last one joining, they have similar objectives, but they have also specificity there that is related to the regional healthcare system. So 20 plus regions, each of them has its own healthcare government. So this makes complexity even higher. What has been the result of this adoption, of this implementation of the Valve for Life program? The first 3 countries reported an compelling success in the program. New countries will report soon on the progresses of their program, and we are in the process of revisiting a bit what should be the medium to long-term strategy of the Valve for Life program and whether we should have different objectives. Let's have a look at the achievements for Portugal. Look at this. It is remarkable to see that since the inception of the Valve for Life program, whether this is play of chance or a causal relationship, but there has been a steep increase in valvular interventions ever since, which has been, we have to recognize this, been mostly dragged by the adoption of TAVI. That is where most of the increase has been observed here in Portugal. What has been the successful Portuguese recipe according to this slide that I think I stole from Rui or from one of his presentation? It was first of all raising awareness around the problem. Improve diagnostic pathways in order to identify the best patients who would benefit about this therapy. And of course, facilitate access to healthcare systems and of course, securing funding for device reimbursement, which is always the same problem everywhere. Poland, same trend. So the fact that a pattern is seen in all Valve for Life country means something, means that there is indeed an added value in implementing this program at the national level, because Poland has almost reached the target that Valve for Life has proposed to the countries joining, which is 80 TAVI per million inhabitants. The Polish recipe, very much alike the Portuguese one, raising awareness vis-à-vis patients, but also vis-à-vis other healthcare professionals. How? Through web-based resources, publication in highly ranked journals, presentation at congresses, and that is the first novel element here, trying to involve other subspecialties, in this case, imagers, expert echocardiographists, who are the ones on the front line to really select and identify the best patient that would eventually land in the cath lab. This is the situation in France, the third of the first 3 pioneer countries, and again, a same trend was observed, an increase in the adoption of TAVI. French recipe, raise awareness again, gathering quality data, quality national data. Why? To demonstrate to the payers on the favorable impact on healthcare system. And this is another element of novelty. They used the Valve for Life program to facilitate a healthier collaboration with cardiac surgeons that was not at all evident at the time the TAVI program started in France, apparently, but also in other countries, I assume. What are the strategies for Valve for Life? We don't have yet achievement there. We don't know yet whether this recipe will be successful, but listening to our UK colleagues, I suppose it will be the case. This is what our English friends are putting in place. Lobbying within the NHS system for implementing this fast-track TAVI pathway, implementing strategies for expanding TAVI capacity, media campaign, so again, raising awareness, transition of focus to mitral leaflet repair. So interestingly enough, they have a step one or stage A, where they concentrate on TAVI, and stage B of the Valve for Life program, where they concentrate on TEER. National public awareness campaign and screening. They are going around for UK with their bus, with the volunteers, physicians, with their stethoscope, listening at the chest of elderly patients, even in the most remote places in UK. And if they find a murmur, they direct these patients to a more advanced diagnostic assessment. So that's what our friends are doing. Italy, this slide is again stolen from Francesco, from one of his presentations, just to tell you what is the situation in Italy and the large scatter between regions and regions. And in Italy, they are working in the same directions in terms of raising awareness and producing quality data through registries to convince the payers there that it is the right way to go. Can we apply now the same lessons learned also to TEER? Let me start sharing with you the second part of the French experience, because one of the chapters of the Valve for Life program in France was related to lack of reimbursement for patients with secondary mitral regurgitation that were not included at the time in the MITRAL FR registry in the primary mitral regurgitation. The action plan was to run a prospective registry during 2 years where they included in a mandatory fashion, because otherwise they wouldn't get reimbursement from the government, all patients treated with TEER for mitral regurgitation. This registry was named MITRAGISTER, and it was an observational follow-up of all the patients managed with severe mitral valvulopathy who were not eligible for surgical treatment, within the frame of Valve for Life program. All patients, as I said, were included in this registry, and this was mandatory by the health authorities. Perhaps this is the best way to gather quality data if we are obliged to do so. And this is the impact that the program had on their mitral valve, percutaneous mitral valve interventional program. Also here, we saw really a steep increase in the mitral intervention, which led, of course, to a reimbursement system that improved. So in a way, they could use this quality data to, as a leverage vis-à-vis the payers. How do we see now mitral and tricuspid interventions in the next years? Well, I think we should continue promoting knowledge on transcatheter interventions and increase number of procedures and reduce disparity among countries and regions. That's actually the motto of our For Life program. Organize in each country centers for simulation lab to understand and educate procedural technique by hands-on training. I think the field is now mature to discuss about this new frontier. Facilitate cross-disciplinary collaborative initiatives to optimally tackle a more complex and multifaceted disease. Let's say it all, let's admit it. This is just not a valvulopathy, that's a cardiomyopathy, and that the challenge comes from there. We should tackle this differently. This is an example from our partner, PCR, on a dedicated multidisciplinary group just working on tricuspid regurgitation. And look who's in this group. 90 members, different specialties, not just intervention cardiologists, not all the world is around us. There are also heart failure specialists, surgeons, imagers, electrophysiologists, health economics, and innovators. This perhaps is the best way to go to push the field forward. Simulation-based training, we discussed about this, but that's just an example of what you can find at PCR. And by the way, shortly, we're having PCR London Valve, and I'm sure there will be SUIT lab where you can train on this. And I cannot conclude this lecture without giving credit to this amazing effort that one of your country-made has hardly worked on. Rui Teles, again, the credit goes to him and to Eric Van Belle, who have prepared the new core curriculum of EAPCI related to structural heart disease intervention. It is extremely well done. Rui is struggling to get it published, but soon it will come out, I'm sure. But this is an important piece of the puzzle that is missing, to provide a reference to our colleagues on the way we as a society, as association, see the best training, education, and delivery of this therapy. Long-term strategy, let me share in the last couple of slides, how do we hope to keep Valve for Life program preserved, durable? The objective will always be the same, an increased treatment of severe valvular heart disease by 20% within 4 years from adherence to Valve for Life initiative. That is always the same requirement that we want to preserve. We have to extend the Valve for Life initiative from the initial pilot countries to additional underserved regions in Europe. We cannot just stop the program to the countries that joined so far. One idea is to form program ambassador to help disseminating the program. And we need to explore new model of engagement. Resources are not unlimited, and we have to take this into account. Currently, the Valve for Life Oversight Committee is responsible to endorse and oversee new Valve for Life countries while seeking for centralized, unrestricted industry funding. That's the way it worked for the 5 countries you have seen so far. What is the contra of this model is that budget is more and more limited. And of course, with limited budget available, there is also limited access to new Valve for Life countries in the program. What are possible new models? Valve for Life Oversight Committee would still continue to exert this endorsing and overseeing role to warrant standard quality of the initiatives that are deployed at national level. But perhaps we can be more liberal. We can open more to the country level in order to seek for funding, because there are some regional specificity that cannot be simply captured at the central level. And companies, industry partners might be more willing to deal directly with the national champions instead of going upward in Europe first. And of course, the pro of this model would be significantly increase the number of Valve for Life countries joining. And here I come to my conclusion. We can certainly learn from the TAVI lessons in several successful Valve for Life national campaigns. TIER, we have to admit, is somewhat more challenging related to the higher complexity of the problem. The more we do it, the more we learn that it's not just a valvulopathy. And we need to seek strategic partnership with other companions. We've seen the PCR tricuspid group. Perhaps this is one of the models to follow and to apply also at national level. That's perhaps the best way to go. Thank you very much.
Thank you, Dr. Barbato, for this interesting presentation. And now we continue with MITRAL. MITRAL valve intervention, old problems, new solutions. It is presented by Dr. Manuel Panalvarez Osorio.
Obrigado pelo convite para participar novamente na vosa reunião da APIC. É sempre prazer estar con colegas e amigos portugueses. My presentation is about the mitral valve intervention, old problems, and new solution. But for many times, we have the same problem with all solutions. So mitral valvuloplasty was used in our center for many years, from 1990, and solved a lot of mitral stenosis. We have a lot of activity in this pathology and with this technique. Perhaps the article that may summarize our experience is shown here, published by Elizabeth George, that was the base by her doctoral thesis that was presented at Coimbra with, as can you see on the left, with Lino Patricio, Lino Gonçalves, and many Portuguese friends. Also, an old solution was used for the mitral pathology, for mitral regurgitation, the H2H repair, used during many years, also in our center. I would like to highlight the article that was wrote with the Portuguese Society of Cardiology at the time of Rui Campante Teles as president of the APIC. Was a collaborative study that summarized the position of both society regarding this technique and this pathology. The new solution are the valve. The valve, we have less experience because it's more recent, the acquisition of this technology, and we can implant valve in valve, valve in ring, or valve in MAC. These are the three possibilities. On the left, we have less experience, as I said, in the course of Dr. Pedro Martín in Las Palmas. We had the opportunity to treat a valve patient. Valve ring was published in Revista Española of Cardiology. And on the left, Dr. Jorge Chavarría was a fellow with us and performed the first valve in MAC in Costa Rica. I am proud of him. So the case that I am going to present is a case of valve in MAC, and the patient was 80 years old, was a male with a prior medical history of hypertension, dyslipemia, AV conduction disorder, with the implantation of a pacemaker in 2013. Aortic valve replacement with biologic prosthesis MITRAL 21 in 2014, and history of chronic coronary heart disease that was treated with PCI with 2 stents at LED in 2019. The current clinical presentation was a progression of dyspnea from 2 years ago, from moderate to minimal effort, being currently in functional class 3, even 4. The electrocardiogram shows normal pacemaker function, and the echocardiogram, the last echocardiogram, shown mild left ventricular hypertrophy with preserved systolic function, severe tricuspid regurgitation, estimation of the pulmonary pressure 92 millimeters of mercury, moderate degeneration of the aortic prosthesis with mild stenosis and mild paravalvular regurgitation, mild moderate, and a mitral valve with severe and extensive annulus calcification and double severe lesion. This is the baseline transesophageal echo. As you can see, it's a massive mitral regurgitation in several views, and in the 3D echo in the lower part of the panel, also the degree of the mitral regurgitation is completely massive. At baseline catheterization, we observe an extensive calcification of the mitral annulus, severe pulmonary hypertension. You can see a pullback from the left ventricle to the aorta. At this point, pulmonary and aortic pressure are practically the same. And also in the simultaneous registry of pulmonary wedge pressure and left ventricle pressure, you can observe a severe mitral gradient. So we are talking about a very complex mitral disease with severe stenosis and severe regurgitation. The CT study is summarized in this slide. You can see first the annulus area that was high, 840, 860 approximately. If you try to implant the biggest MyValve valve, the 32 millimeters at nominal value, you can have ratio absolutely unfavorable for the implantation, so less than 0%, so the risk of embolization is high. So we decide to increase the size of the MyValve with 6 cubic centimeter, additionally to increase the diameter of the valve. With this oversight, we expect to cover the mitral annulus area and obtain a good fixation of the valve to the calcified annulus. Another problem with the implantation of valve in the mitral position is the possibility of obstruction of the left outflow tract, left ventricular outflow tract. So we simulate the implantation of the valve in the CT and calculate the reduction of the left ventricular outflow tract after the implantation of the mitral valve. In this case, was completely favorable. The baseline left ventricular outflow tract area was 555 square millimeter, and the estimation of the reduction was small. So we say residual left ventricular outflow tract practically similar to the baseline condition. So we decide to go to the procedure and perform a transseptal puncture in a posterior position, insert a safari wire in the left ventricle. We try to cross the surgical prosthesis, but it was difficult. And we decide at this point to continue with the procedures in the monitorization of the ventricle. The dilation of the interarterial septum was aggressive with a balloon, and the dilation of the valve was performed with an undersized balloon because of the severity of the mitral regurgitation. This two maneuver was performed before trying to implant the valve. We tried to advance the MyValve through the safari wire, but a kinking was produced, as can you see on the left. So the valve had to be retrieved, and we changed our strategy, and instead to continue with the safari wire, we perform an external circuit, introducing an heteromo wire from the left atrium to the left ventricle, and the aorta was captured with an snare in the descending aorta and exteriorized into the outside of the femoral arteries. With this circuit, the advance of the valve was possible, and on the left you can see the implantation at the view recommended by the CT. The CT you have in raw view, you have a perpendicular view of the mitral annulus, and the implantation was successful using in this view. After the implantation, you can see a shortening of the valve, and in the left ventricular angiography and the echonavigator technique, an absence of mitral regurgitation was observed. At the same time, the gradient across the left ventricular outflow tract was unchanged, and the gradient across the mitral was almost zero. This is the transesophageal echo after the valve implantation. The valve is overexpanded, but still maintain the competence. In the 3D transesophageal view, also practically non-mitral regurgitation and a good area. And to finish the presentation, some final consideration that has been recently published in JACC in the last year. Is an excellent revision, a consensus paper about the treatment of patients with severe calcification of the mitral valve. On the right, you can see the CT morphologies that are favorable, not so favorable, and really prohibitive. Our case was similar to this shown in this figure. For a favorable point of view, you need a complete calcified mitral annulus in order to have a good fixation of the valve, a good anchoring of the valve to avoid the embolization. But on the right, you can see that the mitral annulus is not completely calcified, so the risk of embolization at the moment of the valve implantation is prohibitive, is really high. The other point that has to be considered in the CT study is the possibility of the obstruction of the left ventricular outflow tract. The new software of the CT allows the calculation of the residual area at the left ventricular outflow tract. If the angle is unfavorable or the ventricle is too small, sometimes the obstruction no recommend the use of the valve implantation. So in this case, in case of poor candidate for this technique, on the left you can see another alternative: surgery if the patient had not serious comorbidity, or new valve that are now being developing. Thank you for your attention. Obrigado.
Thank you very much. Thank you very much. Before we go to our panel, I just have one question, and the question is for Dr. Ricardo Costa. We are doing some centers in Portugal, the baseline trial. And my upfront question is, does it make any sense whatsoever to do a valve-in-valve with a non-supraannular valve? Or putting it in another way, does it make any sense to put a sapien in a valve instead of a supraannular valve?
Theoretically, based on what we know, it would make more sense to go with the other way around. But we have seen, clinical practice, there are anecdotal cases, there are technique that has been evolved. There is even devices are evolving in with some specifics that may allow a alternative as well, applicability as well in this particular scenario. So I don't think we have a final answer for that. I understand based on previous reports, some registries, maybe that's not what we would think as a first option, but I think that's important to have this final answer in a randomized fashion.
All right. Thank you very much. And now we are going to our panel, and I'm a very old-fashioned guy, so we start by the ladies. And so I'd like to introduce Dr. Joana Silva. Joana, do you have a mic there?
Thank you very much, and I thank everyone for the invitation to be here, and I greet my colleagues in the table and in the panel. And I'd like to congratulate all the speakers for their presentations. And I'd like to start with a question for Dr. Ricardo Costa. I think life expectancy is increasing because of our treatment of the patients, which is getting better. And I think we'll see in the future a lot of TAVI and TAVI procedures. Right now, we are using the same platforms for treatment of native aortic stenosis, and we use them for treatment of failed bioprothesis and failed TAVI. So do you think in the future maybe we will need new platforms to treat, to perform TAVI and TAVI, or do you think we can rely on the ones we have now? Also, would like to ask a question to Dr. Saya. Right now, we are the main problem in revascularization of patients with coronary artery disease is because they will go with double antiplatelet therapy to perform a TAVI procedure. So what do you think is the optimal timing to perform revascularization in these patients? I will also like to ask, what is your experience with the administration with adenosine in patients with aortic stenosis? Because I don't have a good experience. I have had some adverse events, so I prefer the IFR. Thank you.
Thank you for this question. It makes sense to think that, yes, we might need a specific approach. That study from Ribeiro that we showed, they showed that depending on the type of surgical prosthesis, outcomes might be different, mechanism might be different, so it makes sense to consider that the treatment could also be different. There's some analysis I didn't show, but there's some mechanistic studies showing that commissural alignment may not be as important as you would think in a native valve. There is studies showing that depending on the frame, depending on the material, you also might have different mechanisms, and different positioning may also be an issue for that. We don't have these answers, we don't have this information. I think that becomes even more important when we think treating patients younger and considering new treatments over time, whether it's a surgical or as a TAVI as a first procedure. That's something important that we have to deal with. As you mentioned, patients are living more and we start to treat them in a younger age. We do have one anecdotal case that we have had TAVR in TAVR in TAVR. It was the first patient. He was treated in 2009. It was a core valve. It was like 6 or 7, actually I have this case to show, but 6 or 7 years later he degenerated, and because of his overall clinical condition, we did a second TAVR, which was another self-expanding now, an Evolut R. And then this patient have let's say a short timeline for a new failure. I think we post-dilated this patient, trying to get a better result in the second procedure, and he became with important insufficiency in 2 years. And then was a SAPIEN XT implanted. And this patient is just doing fine. He's a physician, by the way. He had to be a physician. So, it is possible, and of course there are issues, to be deeper in the first procedure and then be supraannular. I mean, there's a lot of technical consideration into this, but I think we'll learn over time, and this patient will definitely become part of our routine practice.
Thanks for your questions. Number one, timing of revascularization. I think that, let's say, most of the time, for the reasons that you mentioned, it is better to do PCI after TAVI, with a very few exceptions, only when you think that really the lesions that you have in front of you can really make your TAVI procedure very high risk. So in that case, maybe worthy to revascularize up front. We just published the data of also from coming from the Revasc TAVI registry multicenter. I showed some other data, but this was just published. The first name is Thomas Reud, and the group of Marco Barbanti coordinated multicenter. It seems that all the parameters are better in patients treated after TAVI with PCI. But this is, of course, retrospective data, so this is not solid evidence. But the rationale behind that is exactly that when you perform TAVI with double antiplatelet treatment and so on, you may increase the risk of bleedings and so on. And in fact, if you think also about the trials testing double antiplatelet versus single antiplatelet treatment overall with TAVI, all the advantage of single antiplatelet that now is the standard of care comes in the peri-procedural phase. Okay, so this is in general, I think that this is where the data are going. Is not solid evidence, but still more or less I think this is a general rule can be taken. Second question about adenosine. I participated to the FITAVI trial with Flavio Ribichini. So we did several also evaluations before TAVI with adenosine. My impression is that it's more dangerous than nitroglycerin rather than adenosine. We did not have, honestly, major issues, but still, because of the rationale that I showed, it will be better to do the evaluations after the implant of the valve. So, in general, if you want to avoid issues, but it's so short-acting adenosine that most of the problems that we had were very transient. Whereas I had, persisting low blood pressure with the nitroglycerin.
Yes, because I have had, I think, 2 patients with a severe adverse event with persistent hypotension after adenosine, and I stopped giving them whatsoever, at least with aortic stenosis in the evaluation of coronary artery disease. I still use IFR, but not FFR, because of my personal experience, not because of any data.
No, but indeed, I think this is an important observation. And actually, this, for example, the study that I showed about the CT-FFR, from the title, they start saying adenosine-free, physiological evaluation. So it's something that, of course, may be an issue.
Okay, thank you. Dr. Duarte is a gentleman. I'm not really a feminist, but I continue what he started. So I'm going to do the presentation of Marta Silva to be the next speaker.
Thank you. First of all, good afternoon to you all. I want to congratulate all the speakers. There were very, very nice presentations. And I want to thank especially Professor Barbato for his presentation. It was a very inspiring presentation for me as a young interventional cardiologist who is starting to my own pathway in mitral valve intervention. And I've learned a lot. I really think that and myself, I'm learning the technique, but we also have to learn with other colleagues, with heart failure specialists. We also have a lot to learn with the cardiac imagers, also with heart surgeons. And for me, it was a very inspiring presentation. So I want to comment that. I don't know if Dr. Alvarez Osorio is with us. because I wanted to ask some practical questions about the case. Yes, I would like to ask you two questions about this case. One question is about the oversizing of the prosthesis. In this case, we had a severe mitral annular calcification. Do you also consider to oversize the valve when we are planning to intervene over an annulus or over a mitral prosthesis? This is my first question. And the second question is, I noticed that you used fusion imaging during the procedure, and I would like to know your opinion about the using of fusion imaging in MAC specifically to position the valve during the implantation. Thank you.
Thank you. Thank you for your question. Regarding the first one, oversizing, in general, we extrapolate our experience of TAVI in MAC. So a good oversizing maybe about 10%, depending of the calcification of the valve. If the valve is very calcified, you can oversize 5 or 7%. And in case of valve less calcified, 10% I think is a good oversize. But I think there is no definitive rules to recommend. We were afraid about the embolization of the valve, so we use, according with the recommendation of the company, the maximum oversize of the valve. 6 cc is the maximum. I think is even more than the maximum recommended. But in this case, I think the valve was fixed and obtained an excellent result without the embolization. That is the most terrible complication during this procedure. That the percentage in some series is maybe even 10%. So this is our opinion. We have not a big experience like in mitral valvuloplasty or in the H2H repair for the treatment of the mitral valve. But in our short experience, we think this is our opinion. And regarding the fusion imaging, in all the complicated case, we always use fusion imaging. In H2H repair, in general, sometimes in complex LAA occlusion, and for this case, we decide to use the fusion, and I think was useful and provide some information during the procedure. Also, in case of pure aortic regurgitation without calcium, we also use the combination of echo and the fluoro. In general, we reserve the fusion image for complex procedure.
Okay, thank you very much.
So, Bruno, it's your time now.
Okay, first of all, congratulations for all your excellent presentations. I wanted to ask Dr. Ricardo a question about if he anticipates a bioprosthesis valve fracturing, if he needs to do it, what you think is the best technique? You showed us about 2 techniques about preventing coronary obstruction, basilica, chimney. What do you think would be the best one in that setting, and how would you stage in the matter of stepwise procedure about that? And also a comment about if you think that these new devices that come with more commissural alignment when we're treating native aortic stenosis, if they bring something, if they add on something when you have a bioprosthesis failed valve. For Dr. Francisco, I wanted just a short comment also about if he would advise us to do whenever we see in a coronary angiogram, in a study, if we feel like, if we find intermediate stenosis, if per protocol you would advise us to do a physiologic assessment, because you showed us that sometimes there's a big portion of patients that lowers even the syntax score. It gives us another setting, because you were advising us to do only physiologic after TAVI implantation, but I always get a little bit, I want to sometimes before doing a decision know the whole story about my patient. What do you advise us, and what type of physiologic assessment? Thank you.
Thank you. Regarding there are two questions, right? So one regarding the technique. We don't have that expertise. We don't have the experience. Still, the numbers in Brazil are relatively small due to reimbursement issues. Nowadays, we are performing, this is a 210 million population, and we do around 3,500 TAVRs per year, which is too small. If you compare to the United States, they're doing this 20, 30 times more. We expect to increase numbers as it becomes reimbursed by the public government. That's something that society is working on. But nevertheless, the ones that had some more experience with this, Basilica is more time consuming, right? It's a more difficult technique to perform. You know, there are several steps that I think only highly experienced operators can deal with it safely. The study that compared both techniques that was presented, PCR, Basilica, had more per procedural complications in terms of bleeding, major bleeding. You also require more time during procedure. The other technique, there was some numbers, numerically higher numbers of cardiac mortality. But these are like registries, there's learning curves. This was a comparison. There was a prospectively performed the Basilica cases, and it was compared retrospectively collected Gemini cases. So honestly, we don't have this answer, and I myself don't have enough experience to give a final answer into this. You had a second question?
About the devices that come now with the alignment, commissural alignment, treating native vessels, if they bring something.
Well, for valve-in-valve, there's one mechanistic study that I mentioned that demonstrated no impact on that in terms of the flow dynamics. So we don't have, at least for what I know, we don't have more data. Besides that, we know surgeons do commissural alignment. We are learning that might be beneficial for native vessels, for TAVR as well. We need studies to prove that hypothesis. As of now, I don't think we can say it's needed, or it can improve outcomes.
Okay, regarding your questions about intermediate lesion, my answer is a clear no. In this setting, the evidence that we have from the activation study, I know I highlighted the limitations of the study, but it's what we have now. And what we know now is that in general, we should try to avoid over-treatment of this patient, because it's dangerous without giving any clinical benefit. So if we still can have some rationale to treat very proximal lesions of major vessels, there is rational, but again, there is no support of the data, because proximal vessels overall were also in the activation study. So I think in this moment there is no absolutely evidence or even the rationale to go testing intermediate lesions. Of course, I think your question is more about, you have a very proximal LAD. So this is something that can change, and this, I go again to one of my considerations, you have to put into the context is not lesion-centered, but should be patient-centered. So of course, if you have a 90-year-old high-risk patient, no angina, I think in this case, of course, you use whatever you have to do the best evaluation of the lesion, but with the idea in mind not to treat. If you have a young patient, low risk, maybe in this low risk also bleeding in case of double antiplatelet and so on, then, I mean, you do, like for left main, you know, you have an intermediate left main, you do the IVUS, and so I think in clinically relevant lesions in a patient in the correct clinical context, I think you can do what you have. And when I use a physiologic evaluation, I agree with the colleagues, I use mostly IFR now, in this moment. Just I have the microphone, I take the advantage to congratulate Dr. Pan, because that was really a great case, very nice case, well conducted.
Claudio, last but not the least, I think. I have to ask you to be short in your questions, because next in the 3:30 we have the opening ceremony.
Okay, perfect. So to be very quick and short in my comments, or asking for a comment, first of all, I would like to congratulate the speakers for the great experience that they shared here with us. I would like to hear a comment from Professor Barbato regarding the need to ramp up mitral valve intervention, because we see, for example, in our country, that there is some kind of slow enrollment of patients, or slow referral of patients for mitral intervention. And I feel always some kind of anxiety to see mitral intervention growing at a pace similar or resembling TAV intervention. How can we manage this problem of referral? Do you see the picture of a problem of referral in Europe, being in Valve for Life, involving in Valve for Life initiative?
Well, I will be very short. You need to search for patients where these patients are. And these patients are normally best managed and best followed by heart failure specialists. Work closely with heart failure specialists, you will find lots of these patients to treat. And with them, you will find also the best indication as to when perform mitral valve intervention. That's the most honest answer I can give you.
So I guess it's a wrap. Thanks, everybody. Thanks for Dr. Pan. I see that you are still on scrubs. Have a good day at the lab. It's a wrap. We are going to the opening ceremony. Thanks, everybody. Thank you.
Thank you.